Good evening, everyone, and thank you very much for making the time to join our monthly interprofessional education hot topic series. What we try, for those of you who are, maybe it's your first time attending this series, what we try to do, we try to align and match a hot topic or an area of need as identified by our students in health sciences with a healthcare team that is already working in that area and has expertise in that area. And the goal is really to advance interprofessional education and interprofessional learning for our students. These sessions are hosted typically face-to-face, or they were hosted in the past face-to-face at Queen's University, and now we've moved into the online world. But I do want to mention that Queen's is situated on traditional Anishinaabe and Haudenosaunee territories. And I do realize that acknowledging the land is a very simple gesture, but it is an important one. And it's an important stepping stone to help us learn and unlearn about oppression, privilege, and the history of colonization. It also helps us build and strengthen relationships and align ourselves with the struggles against system of oppression by taking action and really by honoring the truth. And on that note, I'm actually absolutely delighted that that tonight we have an entire healthcare team from the Tyendinaga Mohawk territory, and they will be sharing their learnings, their stories, and their knowledge with us on Indigenous Interprofessional primary care. I will turn the floor to you and would invite you to introduce yourself. We're really looking forward to hearing and learning together.
Thank you. My name is Susan Barberstock. I'm the Director of Community Wellbeing here at Mohawks of the Bay of Quinte. So I oversee all of the health and social programming here on the territory. It's a big task, but we get it done. And so, you know, this is just one piece. And the team that is here, I'll just introduce them. So we have Kendra, who is our medical admin office administration. We have Dr. Sloan, who's our physician. We have Sarah Taylor, who is our nurse practitioner. We have Kiowa Bernhardt, who is our registered nurse. We have Sierra Bedford, who's our registered practical nurse. We have Jamie Kring, who's our community development worker. We have Darcy Reid, who is our adult mental health worker. And we're currently, our cultural coordinator is vacant. Everybody has a piece in this presentation, so you'll see them pop up later on in this presentation. And so oops, I keep forgetting I'm controlling the presentation here. So I have, how do I go to the next? So our building where we are in our traditional name, and I apologize because I am bad for our language. We've called it the place where there is good medicine. And so we wanted to make sure that we captured why people are coming to us. So it's not just about that physical health piece, it's about that good medicine all around. As part of our team, we do have the other nations represented on our advisory committee, and it's for the Anishinaabe naming that has been put on the group who come from the Anishinaabe territory. We're currently located at 45 Meadow Drive here on the territory. This is our brand new building. We've just moved into it, and we had plans of how we were going to fill it, and COVID hit, and so now basically we could say that our building is too small because we can't do a lot of our physical distancing and how things are supposed to run. So we'll have to figure out how we're going to do that, but we have a large territory that we're covering. I've only been in this position for 3.5 years. And so one of the first tasks when I started was actually writing the proposal. It was a long-term goal that we would have our own primary healthcare team here on the territory. But with the call for proposals that was out within the ministry, it was not just about here on the territory, but it was about that larger area. And so, when we say we cover off what is the Southeast Lynn area, people go, how? And we go, good question. So I'll get a little into that about how we're trying to make it work, because we are a fairly new team, and we have many different personalities sitting at our advisory table on how we're going to make that work. So, looking at being culturally based care. So it's not just about the Haudenosaunee people, but it's about what other people, all the FNMI within our territory, within that area we cover. Our team is, it's unique, but it's not unique. This has happened across the board throughout Ontario. Previously, under the Aboriginal Healing and Wellness Strategy, they created all these Aboriginal, or now Indigenous, health access centers. So with those health access centers, it was about, making sure that we're looking at all aspects. So, all those social determinants of health and how we work together and what does that mean. So administratively, it's Mohawks of the Bay of Quinte that hold that sort of overarching title of looking after this and where it goes, but our long-term goal is that it becomes its own standalone health access center to cover with different satellite offices that's able to cover off such a vast area. Our governance model, we have our regions, so we have the rural, on and off reserve status, non-status, the Inuit, the Métis, and the different traditional territory holders. And why we've added that piece in there is because there are some people who don't have land base, but they have the title. So that's sitting there. And I think the struggle at the beginning was trust, right? And it takes time to build trust, because you could honestly say the off-territory, off-reserve population was saying, you're just using our numbers and you're just going to run it right on the Mohawk territory on Tyendinaga, and you're going to forget about us. And so I think being able to say to them, no, I come from that background. That's where, I lived off the territory. I certainly know how that feels, and I would never let that happen. So it's still been a bit of a rough time, I'll say, trying to build that trust and to make sure that they know we're going to look after everybody's needs, but we need cooperation and we need respect and we need to be able to work together. So we have the Indigenous Regional Governance Circle and we have the Mohawks of the Bay of Quinte. And then it goes, me and then the manager of the Indigenous Interprofessional Primary Healthcare team that we are currently without. So I do this off the side of my desk also, is managing that team. Fun. So our vision for the IIPCT is that, all Indigenous people receive friendly, warm care where they are. So it's not about them having to come here onto the territory, but we can actually go to them, or doing a lot of that cultural competency that if they're already involved with a primary healthcare provider, that we're working with them so they feel safe that they can continue with that. So geographically, we don't see any boundaries and we're status blind. So whether you belong to Mohawks of the Bay of Quinte or you belong to the Algonquin or you're Cree or Dene from out west, then it doesn't matter. We're status blind. Or if you're somebody who just identifies and is an ally and that's something that you want, so then we will allow people to access our programs and services even though they're not Indigenous. It's emotionally, it's care that is provided in a safe space, which is defined by the client. So asking them, having those conversations, what would make you feel safe? Culturally, it's the care that respects wherever the clients are in their spiritual journey and however they identify culturally. So, some people have huge knowledge base and some people have no knowledge base and they just know that they want to belong. And so that's why it's, we don't judge, and it's whoever is, if you identify as Indigenous, then, the door is open and welcoming. Physically, it's care that treats all medical needs and addresses the complexity of care. So again, it's looking at holistically at the individual. Our generosity of time and skills is shared freely. So again, looking at how do we work together to ensure that the Indigenous population is receiving the best care possible, whether they're with us or with another primary health care. And our traditional ways of knowing and being are valued and separate and celebrated. And so it's, like I said, it's not whether you belong to Mohawks of the Bay Quinte or who you belong to. It's about how can we celebrate you and how can we foster where you need to go. Our mission to accomplish this vision as the regional team. So looking at providing holistic primary health care, equal values and traditional healing and clinical support. So making sure that, if somebody wants to do that Western medicine, then absolutely, but they want to, have some of that traditional supports, then absolutely working with the primary health care providers to ensure that, we're doing what's best for the individual and how we're meeting those needs, whether it is walking in both those worlds. Connecting the Indigenous people to regional services and professionals whom they can trust. So again, building that competency level of, cultural competency, which is in turn going to create culturally safe spaces. Engaging all the Indigenous communities across the region. There's different pockets of Indigenous people in the urban centers and in the rural centers areas. And so how do we work with all of them? It's shaping the care and the service based on the needs determined by the people in our regions. And that's why we have a community development worker, so that they're able, when we're able to, go out into the communities to have those conversations of, what do you need and how can we help you, and what can we do to foster and build those relationships. Our values, everyone who walks in the door is treated as family, and our community builds community. So it's about how do we work together? How do we do everything that we need to do together to accomplish our vision and missions? We look at the two-row wampum, and that's a whole teaching in itself. And it's about, how, what's the word I'm looking for? It's about that self-determination, but it's also about doing that doing the teaching around it. And it's about how there's that, I'll say that Western boat going down and our canoe, and how we're both going to be in our own boats, and we're going to travel that waterway together, and we're not going to interfere with each other's steering of those boats. So it's a whole teaching in itself. And so throughout this presentation, we're going to touch on some of those teachings, but just barely skim the top of it, right? So it's looking at how do we incorporate that Indigenous healing approach in, as well as looking at those clinical healing approaches, right? So making sure that we let the people have those options, and how do we work together so that, there are some medical Western approaches that people just have to have, but also they can have that grounding in their own traditional ways. The one dish, one spoon is a teaching again. It's about sharing our values and our knowledge and attitudes with Indigenous people and their families. So it's about, we have this knowledge, but we have one spoon about how we're sharing. With COVID, we wouldn't be able to do that, but it's how we're looking at those things, right? And how we do that sharing. Our mandate is to promote holistic health, prevent ill, treat illness, and support our Indigenous communities and their families on their journey through these realities. We do this by providing services that equally draw from both Indigenous and mainstream ways of knowing and being, all done in active cooperation with our partners. Who do we serve? Our priority population are those that are who identify as having an Indigenous ancestry, and their families. So sometimes you may have mom or dad who's Indigenous and the other partner is non-Indigenous, and so it's being able to provide that for both of them so that they can both learn and that their children have that option, right? So it's a special focus on people at risk for and living with chronic diseases, as well as people living with mental health conditions and or addictions. And as I said previously, all of our services are status blind. So we don't say, are you a card carrying member of which nation, and prove it. It's if you identify and you walk through the door, we're there to help you. As I said, we cover a huge area. So, we have the Tyendinaga Mohawk territory, we have Napanee Deserono, Ardoch First Nation, that's within that one sub-region. And then with the other region, the Algonquin First Nation, Madoc and North Hastings. And then we have Belleville, Picton, and Trenton. So it is a huge area that we cover. And so we're not going to be able to be strong in each of those areas, but we're going to be able to provide services of some sort in each of those areas to ensure that people have access to programs and services that are culturally competent and culturally safe. This is where, and then we're in the Kingston, so within the city of Kingston, and then we have Perth, Gananoque, and Smith Falls. So that is a huge area, as you can see from this map, that we have to cover off. So what we're focusing on right now is, let's hone in on our programs and services that we have on the territory. And then I don't want to say take our show on the road, but then we're able to build those relationships in the communities as we grow and as we go on. And then we can, make sure that we're providing the exact same, not the exact same, because we need to meet their needs, what programs and services if we need to adapt them to meet their needs. Our partnerships and engagement is, the circle operates under our traditional principles. Relationship is key to our community and our life. And it really is, that relationship makes us stronger when we work together to meet those needs. So, all of our members have made a commitment to working as active partnerships, and we recognize that we all come from different Indigenous backgrounds. So we're not going to say, it's you're going our way or no way. It's adapting our programs and services to meet the needs, and like I said, meet people where they're at, because it is such diverse Indigenous populations throughout that large geographical area. looking at those, FNMI people throughout the territory. And community engagement is key. Partnerships are critical, and understanding of our communities that we're involved with, building on their strengths, their needs, and how can we help. So either through direct partnerships or just making things available for them that they're able to access ours or help shape what they're already involved in. Our programming, some of the action plan, we want to be clear that health is enabled both through that Western and traditional evidence-based medicines and practices. Cultures and our culture and our skills of everyone involved in the team has to embody this understanding. Our services that are offered across the region have to look at what are the pressing needs. And a lot of times we are adapting to what is the issue du jour and how can we help. But we're trying to not be reactive and to be proactive. So based on our conversations with our communities and our people at our advisory committee, we're hoping we can be proactive and making sure we have that forward thinking of where we're going, where do we want to be, giving ourselves those benchmarks. We're continually improving on our programming, and our circle aims to represent the diversity across the regions, right? So when you look at the people who come from up the coast that are in Kingston, and if they have to stay in Kingston, or people who are involved in the justice system, criminal justice system, and their families have come to Kingston. So it's about looking at what's in the communities, how can we improve, and how do we get the involvement of our Indigenous population in the urban centers and the rural. What services do we offer? We offer a lot of services. We have our traditional healing services, and why we call them the cultural coordinator is because we want them to ensure they have a list of resources of people that we can call upon. So it's not just, again, as I said, ensuring or making it our culture available, but it's the diversity of the culture available. So that's why we thought that in our planning that we would involve a cultural coordinator so they can coordinate those services. We have our primary medical care. We're working on our blood pressure outreach program and our prevention, our prevention programming. We do smoking cessation. We have our adult mental health and addictions worker. We do health support services, and we have specialist services. So we've created relationships with some of the professionals in the community outside of Mohawks of the Bay of Quinte that we're able to engage with, those that are champions and those that are allies, and understand who we are and where we're coming from. I put this slide in there. This is all of the First Nations in Ontario. We didn't really want to get into a big cultural competency piece with this presentation, but felt it was necessary in the sense of that people draw on the understanding of working with the Indigenous population. A lot of times when I'm doing cultural competency training and I say, is there anybody in the room who doesn't have an Indigenous person on their caseload? And, a few people will raise their hand, and I'll say, I find that hard to believe when you look at the number of First Nations in Ontario and how close you are to this First Nation, and remind them that Indigenous people are not your stereotypical Indigenous looking person. We have people who are blonde hair, blue eyed, and red hair with freckles. And so it's about them feeling safe to say, yes, I'm Indigenous. Or, I talk to them about, did you even ask the question, are you Indigenous? And sometimes people say they don't want to offend, and that's why they don't ask. So to me, it's more offensive to not ask, because there's so much more you can offer somebody in working with them once you understand that they're Indigenous, and if they're looking to work towards that, or that's something that they can do. This is a medicine wheel for personal wellness, and it's also the basis for looking at an individual holistically. So in looking at that, when you look at your spiritual aspect of somebody, so it's about, are you doing that prayer, that meditation? Are you doing daily gratitude? Do you have faith in your future? Are you honoring your relationship to your spirit of creation? Are you engaging in cultural activities or spiritual ceremonies, or being honest? And I always say to people, sometimes because you didn't grow up with that cultural piece, they still have that spiritual connection, and whether they're going to the church. So it's still, what is your spiritual connection? Physically, do you have good hygiene? Are you consistent in your sleep, healthy eating, exercise and motion? Are you looking at engaging in relaxation techniques? Are you honoring your sexuality? Emotionally, are you expressing love, seeking support from caregivers? Are you talking to someone you trust? Do you have emotional expression? Forgiving yourself and others? Are you writing, journaling? And then mentally, are you looking at a higher education or fulfilling your career? Are you reading positive and relaxing books? Are you focusing on positives in life, continuous learning and goal setting, staying organized, art and creativity, believing in yourself, living that clean and sober life? And in the middle, it's about love and respect for yourself, right? And how you have that. So as a quick little wellness check for yourself, if you have a piece of paper and pen in front of you, if you can draw this circle, and as you see, I wasn't too handy with how to put little hash marks in there. So if you look at the middle of this circle being a 0, and the outside of the circle for each of those, I'll say quadrants, being a 10, and rank yourself in each of those areas. So where would you see yourself physically? Where would you see yourself mentally, emotionally, and spiritually? And then, and then connect the dots in a sense of, did you make a perfect circle, or is your circle an oval? Is it lopsided? So, physically, I've been overworking myself and not paying attention to what I need to be doing in stress eating. So I'd really give myself about a 3. Where do I find myself mentally? I'd say it's pretty good. So I would give myself, a 6. It's not a 10, but it's a 6. Emotionally, I would say about the same. And spiritually, I just, I give that thanks daily, and I do what I need to do, but I haven't immersed myself. So I'd say about a 3. So it's really not a balanced circle. You don't have to be a 10 on everything. But if I was a wheel going down the road, it wouldn't be smooth for me. I would be like choppy as a wheel. So it's about, what do I need to work on to get that balance? And as I said, not everybody's going to be a 10, but you can work towards that. So what do I need to have that balance in my life? So, do I need to look at something, whatever, and give yourself some goals? So this is a big part of who we are and how we work with people, just making sure we're focusing on all these aspects of an individual, and not just looking at the medical needs of somebody, but what are some of the other things that are impacting on them? This is what we call the healing continuum. And this was something that was developed with the Indigenous healing and wellness strategy that a lot of things are based on. So in the middle, it has that physical, mental, emotional, and spiritual aspect of the individual. And then on the outside, it has this, what we call the 7 stages of life, although there's 8 there. And with the teachings on the 7 stages of life around that, we all have, at each of those stages, there's something that we bring. There's a gift that we have. And so the easiest one to talk about is the youth, right? So as a youth, your job as a youth is to wander and wonder. But it's about wandering and wondering within parameters. I always think back to when you were in high school. It wasn't that long ago. Who am I? What do I want to be when I grow up? Like, when was your aha moment about, I want to be a doctor, a nurse, a lawyer, a fireman, a pipe fitter, or whatever, right? So it's about having that opportunity to think about who I am and to do that wandering and wondering, right? And so I think that's sometimes where we fall into an issue of people go right from a youth to being a parent and they're not a young adult. So we'll find sometimes people who were young parents, you know, falling back to that wandering and wondering phase because they didn't really complete it. So looking at some of those things. So it's, you know, having that understanding and having the teachings on the 7 stages of life really help you understand where people are coming from and where they're at in their life. On the outside is the healing continuum. And as you see, a lot of times we find that people are coming to us in that crisis intervention piece, right? So they're not doing a lot of those where they should be doing that promotion and prevention to help people not be in that crisis. And you can put this in any aspect of, you know, whether it's an addiction or whether it's, you know, breast cancer awareness or whatever. So it's about doing these and following this process. And we always say the good thing about the wheel is that some people will come out of the wheel and they'll go backwards, but you can always go in. So it's about a process of going around. So it's not about that linear. It's about doing that whole process and the different steps that you would go through in order to, you know, to get on that good path, about that healing path. I won't get into the big history, but I think the benchmarks in history have a lot to do with understanding Indigenous population and about some of our learned behaviors and about just where we come from. And I always use the analogy that, you know, the husband and the wife are cooking Sunday dinner and the wife cuts the ends off of the roast and she puts it in the roasting pan, puts it in the oven and whatever. And the husband says, like, honey, why are you cutting the ends of the roast off? And she says, I don't know. That's what my mom did. So that's what I do. I thought, I'm going to ask her the next time. So the next time he sees the mother-in-law, you know, he says, mother-in-law, like, why do you cut the ends of the roast off before you put it into the oven? And she chuckles and she said, because that was the only size of roast pan I had and my roast wouldn't fit, right? So we do things that we don't understand why we do them until they're explained to us and you think, oh, okay, I didn't really need to do that, but that's what my mom did, right? So my husband is terrible. He won't touch potatoes unless they're wet. And I was at his mom and dad's house and we're getting dinner ready and his mother freaks out a little bit. She goes, oh my God, I can't touch these potatoes unless they're wet. I went, oh, there we go. Like a learned behavior, right? He has no rhyme or reason why he does it. He just does it. So when you look at these things of multi-generations of how things have impacted us. So, you know, it goes right back to 1763, which is about the first cultures meeting, right? So it's about the British government began to recognize that there was a nationhood here on, you know, Turtle Island and that they needed to have a relationship. So that sort of laid the groundwork for that relationship of how they would treat the Indigenous people and how we would go about things. Then in 1857, you have the Gradual Civilization Act. This is the actual first Indian Act. And it defined who an Indian was and it began to count the Indian. And it was really created to get rid of the Indian. It's just what it says. They felt we were that we needed to be civilized. And so how could they do that? So this was the act that was going to, you know, it made our way of life illegal. Our ceremonies were banned, our rights were taken away. And at this point, it became illegal for 4 or more Indigenous people to be outside of their same family and meet together. You could have been thrown in jail. You know, it's the introduction of the Indian agent who can dissolve the chief and council, and they controlled all of the decisions, but it also put our inherent chiefs on the back burner and created the democracy of, you know, of how we would vote for a chief and have those people in there. Although we couldn't vote in, I'll say, the European until 1960. So we weren't even considered people. You know, and the first line of the Civilization Act is that an Indian is not a person. And then you have Confederation. You know, Canada became a country. The newcomers are electing themselves. There's no representation of Indigenous people. You know, the Europeans were coming over here because land meant economy, and there was so much land. So then they felt that the Indigenous people were in the way. So they started putting us on these little reservations of pieces of property they didn't feel that were very worth anything. And so it was a worthless piece they felt they were putting us on. We were now dying more because we were being introduced to these new diseases that were coming over, and we were of less importance. You know, we were in the way, and we were definitely outnumbered. And then you have the Indian Act. You know, the intent of the Indian Act is really best summed up, and this is actual quote taken from Duncan Campbell Scott's letter. And he was the Deputy Superintendent of Indian Affairs from 1913 to 1932. And he says, I want to get rid of the Indian problem. Our object is to continue until there is not a single Indian in Canada that has not been absorbed into the body politic, and there is no Indian question and no Indian department. And that was part of a letter that he wrote in 1920. So you can see that the Indian Act had its purpose and what they were trying to do. You know, it also spelled out the conditions for Indigenous women. You know, if an Indigenous woman married a non-Indigenous man, then she lost her status. But if a non-Indigenous woman married an Indigenous man, she gained status. And that all changed, you know, in 1985. But it's, you know, so you'll find a number of people who are lost, right, who don't have that connection. The Indigenous people, we were required to have the consent of the Indian agent in order to leave the territory. And if you were found off the territory without your, I'll say, hall pass, you could be thrown in jail, and you had to stay there until the Indian agent was able to come and get you. So this is the beginning of the life of overrepresentation of the Indigenous population in our criminal justice system. You have the displacement of our traditional forms of governance and the federally imposed ban system. You know, we had to give up our status, our Indian status, in order to vote, in order to own property, or to serve in the military. So you'll find a number of Indigenous men who gave up their status in order to go and fight for a country, you know, that didn't really do a lot for them. We have amendments to the Indian Act in 1927. You know, you had residential schools, which is a big piece of where some of that, you know, the horror stories that we hear about the Indigenous kids in residential school and some of those learned behaviors. And really, when you look at some of that, it's about the way they were treated, right? So, you know, think when you were a small child, and if you fell down and hurt yourself, that, you know, your mom was probably right there to be able to, you know, kiss your boo-boo better and pick you up and dust you off and get you back on your way. Whereas they had these very strict nuns and other people who were there, you know, who didn't have that compassion, and, you know, basically was suck it up and get moving and do what you're supposed to do. And residential schools were not a good thing. You know, it wasn't about how the education that you would get today. It was more about the girls were domesticated of, you know, cooking and cleaning, and the boys were out in the field doing the farming and those types of things. So it wasn't even about how we learn or what we learn. It was about what was being role modeled. And I think there's a number of, you know, movies and different things that residential schools that you can educate yourself on. The last residential school closed in 1996 out in Saskatchewan. And so I think it's, when you look at some of those pieces of that, you know, how it has oppressed the Indigenous population. You know, we have the 1965 Indian Welfare Agreement, which gave the provincial government the authority to take Aboriginal children. And, you know, you find a number of Indigenous children were adopted or sold over in Europe. And, you know, the repatriation of bringing them back. And if you think about that piece about being a youth and the wandering and wondering, you know, you don't belong somewhere, and where do I belong and how do I fit into that? So that 60s scoop was a big piece, and that welfare agreement giving the provinces that authority created a huge problem of how child welfare authorities worked and how they didn't understand our way of life. And so they didn't think it was right and came in and apprehended children and, you know, put them in these group homes and foster homes. So there's so many things that have happened with that in the 60s scoop. The white paper in 1969, you know, this white paper called for an end to any special status for Native people. And it was aimed to quickly culturally assimilate us into mainstream Canadian society, and that the Indian Act would be repealed, government management on reserved lands would be dismantled, and all federal responsibility for treaty agreements would end. And that died, you know, and is nowhere to be found except on a shelf in government collecting dust. Bill C-31 talks about giving back Native women their rights, so that those that had to give up or what they called enfranchised, then they were able to get their status back and become back to their communities. Then you have the Meech Lake Accord, you know, that when that happened, it gave special recognition to Quebec, and every province had to vote in favor. And it would be interesting today if Elijah Harper was not in the Manitoba legislature, and he was the, you know, it had to be a unanimous yes, and he stood up in the Manitoba legislature and said no. And the accord died right there. So, you know, that certainly gave us back, or not back, it didn't take away from who we are. And it's, you know, still the fight with the government about the treaties, and those are treaties you could get into for days talking about how they impact us and how they haven't been followed. Looking at some of that multi-generational trauma, it's, you know, 52.2% of children in foster care are Indigenous, but really we only account for 7.7% of the child population. This is according to the census in 2016. So that's a huge chunk of Indigenous kids that are in foster care. So this means that 14,970 out of 28,665 foster children in private homes under the age of 15 are Indigenous. Those are big numbers. You know, family violence is huge in our communities because of some of the colonization and learned behaviors and trauma that we've endured. And in 1989, the Ontario Native Women's Association did this big report called Breaking Free. And in that report, they found that 8 out of 10 Aboriginal women personally experienced family violence, and the percentage was high of the children who witnessed that violence. And now, you know, we're seeing different things about how that has had an impact on children witnessing violence, you know, education, you know, the bullying and having to go leave our home communities in order to get that education. And if the supports aren't there, then it's failed. And so we're not seeing a large number of Indigenous students graduate. Now that's changing. We're getting more and more supports, but it's just taken a lot of time to make sure that has happened. You know, unemployment is very, the employment rate of the Indigenous population is very low. And so it's, you know, again, we're overrepresented in many facets of things in society, and we shouldn't be. And it's difficult, not difficult. I always say, when people say, why do I have to have cultural competency, the Indigenous piece, I always say we're the biggest consumer. So how you work with your Indigenous population is transferable to any ethnic group. So it's about that respect. And so it's understanding how things have impacted us. Culturally, I touched on, we look at traditional healing and medicines, the cultural learning and how we can support people spiritually. And our cultural coordinator supplies this service in a sense of creating that list of elders in communities, people who have the traditional knowledge in the community, and making sure it's a right fit, because sometimes it's not a right fit, but making sure that we have that right fit so that people are getting something out of it and that they have that support. So I'm hoping soon we'll get that cultural coordinator to be able to do a lot of that work, because right now it falls back on the staff to do that, which is fine because it's all about that growth too, of the staff knowing those types of services and supports in the communities and being able to connect people to the proper ones. Okay, enough of me. Well, I'll pass it over to our primary medical care.
Hello, this is Sarah. I'm the nurse practitioner here. I grew up as a settler. I'm from Perth, Ontario, so a very rural area. My heritage is French Canadian and Irish. I have been nursing for the past 13 years and NP for the past 8. I've been with the clinic for about a year now. I started before there was even a building constructed. Mind you, I kept quite busy. I have worked on developing policies and procedures. I was lead in implementing and training for the EMR, so the electronic medical records. I have worked with the Alliance for Healthier Communities in developing security and privacy aspects for the clinic. I have given some insight into the daily needs and operations of the clinic. I was involved in hiring the RN. I took over for some administrative duties when it was needed. I have worked with agencies on territory in accessing timely care and results. So for example, one thing I did was construct a medical directive for the community nurses so that they would be able to get their COVID results in timely manner, because it was taking quite a while without it, so that they could go on to do their contact tracing where needed. I've acted as a consult to the midwife group so that they could access OHIP covered testing for their clients. I have provided advisement for infection prevention measures at the onset of COVID when there was very little guidance at that time. I've been involved in initiating resurgence of older programs like the Deseronto Blood Pressure Clinic and new programs like the Ontario Renal Network Chronic Kidney Disease Screening Program. Since June, I've been able to have the privilege of providing primary care to patients of all ages and stages. I act as a clinical preceptor to NP students wanting to learn more about Indigenous health. I practice within a framework of cultural safety and trauma-informed care. As a team member, I frequently will collaborate with Dr. Sloan or the nursing staff. I require the MOA, Kendra, to process everything and keep our daily workings running smoothly. I frequently will refer to the interdisciplinary team for their guidance within their specialty. For example, I would refer to the community developer for the smoking cessation program, or to a cultural coordinator for assisting and welcoming patients to meet elders, traditional healers, to become involved in ceremonies or language teachings. My goal is to promote the best possible health and wellness a person can achieve where they feel balanced. And I think I'll pass it on to Dr. Sloan.
Hi, my name is Jeff Sloan. I'm a family physician. I actually did my family medicine training at Queen's a long time ago. And following that, I went to Northwestern Ontario for a sojourn in Sioux Lookout. I was there for 9 years, and many of you know Sioux Lookout is a lot of Indigenous people living there. And for the first couple of years, I actually traveled to communities north of Sulaga that were accessible only by aircraft. And I've continued over the years since I moved to the Southern Ontario, I've continued to provide services by locums in Sioux Lookout, and for a while also in Moose Factory. I'm originally from Southern Ontario. I'm a settler, a non-Indigenous background. And for many years, I've worked in the Napanee area and provided inpatient services at the hospital there, emergency department services. And then I was brought onto the team last spring. And my CV isn't as impressive as Sarah's. I haven't contributed as much to the organization of the clinic as she has. But it has been a wonderful experience for me to work with the other members of the team and to learn more and more about Aboriginal customs and traditional kinds of practices. I had the opportunity this fall to be involved in a Aboriginal Healing Conference, Health Workers Conference, which was for 2 days in December. And that was quite a powerful experience. And I would highly recommend it for anyone who works with Aboriginal populations to consider it. But I am so impressed by the other members of my team and their knowledge about traditions and Mohawk traditions. And it's a real privilege to work on this team, and kind of interesting to see as my career is winding up. I sort of started in an Aboriginal community, and now I'm finishing with Aboriginal work. And I did have Aboriginal patients in my practice in Napanee until I gave that up a few years ago. But as Susan was saying, I didn't recognize that some of them were Aboriginal because they didn't look Aboriginal or Indigenous. And so it's been a real learning for me to be back in traditional Mohawk territory, and a privilege to work with these people. So, and with all the members of the team.
Thanks, Dr. Sloan. I guess I'll go next. So my name is Kiowa. I'm a registered nurse with the primary care team. Some background information about myself. I was born and raised in Tyendinaga, also known as Tyendinaga Mohawk territory. And it's been my goal since I was actually a child to be able to help my community. And I had a particular interest in helping to improve the health of the community. So this role helps me to do that, not only for my community, but the other communities in our catchment area. So I'm really thankful to be here. A bit about my educational background. I actually just completed my nursing degree at Queen's this past spring. So I'm a new nurse. It's definitely a neat time to become a nurse amidst a pandemic, but I've been learning a lot. I just want to say I've seen a couple comments in the section there. Just wanted to say hi, Dr. Flynn and Cheryl and Courtney. I hope everyone's well, and I miss seeing your faces regularly. So some of my responsibilities, more behind the scenes. So I take a lead in the infection prevention and control measures for the clinic. I'm help with the management of specimens, so making sure that they're stored properly and transported to life labs. I'm in charge of procurement and inventory management for all the medical supplies in the clinic. This was something that was new to me. I think I kind of took it for granted working in a hospital. You go in the supply room and everything would be there for you. So kind of seeing the other end of it, it's been really valuable. And the most important part of my role, client care. So I work alongside Jeff and Sarah and the rest of the members of the team to provide holistic care to our clients. So just kind of echoing what Susan was saying earlier about holistic care. So we're trying to look at all aspects of someone's being while also trying to understand the profound history that affects those domains of someone. And even taking it a step further, it's important that we try to identify the perspectives and knowledge systems that we should be using to help that client. And we do this in collaboration with the clients and with the entire team. Through that holistic lens, I perform health assessments, I triage clients, promote health, manage chronic disease, and perform interventions, to name a few kind of nursing skills there. I also kind of network and help with other community programming. So Sarah was talking about COVID testing, so I've been performing COVID testing, helping community well-being with that program, and that helps community members to be able to get that testing within the community and not go off territory if they need a COVID test. And I kind of wanted to touch on just being a part of this team makes us all leaders in our community. So some other responsibilities that we all have as members are addressing anti-Indigenous racism and ensuring continual development of knowledge. So I spend a lot of time growing and maintaining my professional expertise. And I plan on doing that for my entire career. I think it's a lot right now being a new nurse. So, but this is something that should be happening all the time, and it's important in providing safe care. And finally, kind of reflecting on the healing continuum and life cycles that Susan was speaking to earlier, I just wanted to say that I think it's special that I get to do this work just 500 feet away from the same playground that I grew up on, hoping to do this work, and where we get to see future generations, because that's why I do what I do and why our ancestors did what they did, was to make things better for future generations. Thank you for listening.
Hi everyone, I am Sierra Bedford and I'm the RPN at the IIPCT. I'm a recent graduate of Sir Sandford Fleming College. I actually graduated in November of last year, and I began working for the clinic mid-December of last year. Little history about myself. I was born and raised in Prince Edward County, Ontario, and I am First Nations Mohawk. My role at the clinic is to provide clinical assessments and services for clients with chronic stable conditions and more predictable outcomes. I provide health screening services, whether that's point of care testing or even just helping the CWC with COVID testing in our community. I also support the delivery of primary care and health promotion programs. So for example, immunization, chronic disease prevention, smoking cessation, and also the upcoming rollout of COVID immunization in our community. I also deliver patient education to help clients make informed decisions and direct them to other resources within the community or even different members of our team. As a team, we really support each other in our roles and our different skill sets and what we bring to the table, and we all collaborate together to deliver and plan that patient plan of care that is patient-centered and culturally safe. Being a new nurse in this role, I am really supported in my goals within the role. For example, I'm working towards my licensing exam, so I'm practicing under a temporary license right now. Once I complete that, I want to take an advanced foot care course and other specific courses that will help widen my scope of practice. And yeah.
So I'm the administrative assistant. I kind of support the whole team. A little bit about me. I've been working for MBQ for about 2 years now. I've been in this role for just under a year. There are kind of a lot of things I could say that I do in a day, but a lot of them, so I roster the patients and book any intake appointments, or really just book any appointments. I do triage patients, but for the most part, I would probably transfer them off to Kiowa or even Sierra to kind of help with triaging if I'm unsure. I call patients to remind them of their appointments. I do the screening for COVID. So if they were having to come into the building, then I would screen them beforehand. I scan documents. I also sort through documents that we receive and put them into the EMRs for the doctor or the nurse practitioner. And I send out any information to other specialists or things that the doctor or nurse practitioner need. And more of my administrative role. So I do some ordering and inventorying of office supplies. I manage an overall budget and track our spendings. I support the staff in setting meeting times and creating agendas and typing meeting minutes. Yeah, that's just a little bit about my role.
Is Jamie with us, or is Jamie talking and on mute?
Sorry, I'm with you, but I'll just wait to go to the next slide, please. Hi, I'm Jamie. I'm the community development worker. So I've been in this role for about 8 months now. I've been working with MBQ for 2 years. So I grew up in Tyendinaga here on the reserve. A big part of my role is actually smoking cessation counseling. So I part with getting the STOP program up and running for all of our clients, which is offering 26 weeks of free NRT and smoking cessation counseling, whether that's one-on-one or group therapy. People have the option to bring their spouses. Say right now with COVID, it's a little bit different. We're doing everything virtually or over the phone. So all intake appointments are over the phone, and doing contactless deliveries of the NRT, as well as like program supplies and stuff. Another part of my job is doing programming. So developing, delivering, and evaluating community programming. So some programs that I've ran are a Walk or Run to Quit program, which is a 10-week program that allows people the opportunity to learn how to walk or run 5K while learning strategies to quit smoking. The programming I do is cultural programming. Sorry, bear with me, my ear's plugged today. Social programming such as the leather mint making program, or offering traditional tobacco knowledge through programming, bringing in speakers to that, doing leather tobacco pouch workshop. Right now I actually have a Healthy You program going, which is focused on nutrition with a dietitian, which is actually tonight. And I act as a liaison to help our clients access resources. So funding. Right now, Indian Day School forms is a big one. So helping our clients have access to those forms, help them fill out those forms, being a supportive person for them while they're trying to talk about and bring up those traumas. And yeah, that's a big part of what I do. So I'll pass it on to the next person.
I just got a message from Darcy that she's been locked out of the meeting, so I wonder if Claudiana or Michaela, you can unlock her somehow.
I've unlocked the meeting. I'll just watch for her.
While we're waiting for Darcy to get back into the meeting, I'll just briefly tell a bit of her story, if I may be so presumptuous. But she is our adult mental health worker, and she's from the area also, and she receives referrals from Sarah and myself, and from other members of the team, and from outside sources as well. And she is Masters of Social Work, I believe, and very skilled in working with mental health issues that are culturally based. Susan, was there anything else you would like to add to that?
No, I think even though she's, you know, I'll say in the mental health field, a team of one, she does have the support of the other programs and services here at Mohawks of the Bay of Quinte. So it really has been, you know, how we work together. And I always say, how do we get the best bang for our buck? So it's drawing on other people's knowledge. Sometimes if we don't have that knowledge or somebody's skill on, you know, how we do the work that we do, and just making sure that we work together, because, you know, sometimes we think as an individual and you have this job description and it says you have to do all of these things, but it doesn't mean you have to do them yourself. It means that you have to facilitate it happening. So how do you work with somebody to make it happen? And I think the team with this COVID time has certainly stepped up in how they've worked together and how we haven't been able to take our show on the road, but we certainly have taken the show on the road with the virtual programming and thinking outside the box of how we need to do what we need to do and how do we need to do that outreach to community and outreach to individuals so that they're not feeling isolated and alone. And that's been a big piece of Darcy's job is, around that mental health piece is working with others to make sure that, she has a team and doing some of that case management. Providence Care is, comes to mind, and working with Providence Care and working with other physicians who can do that mental health piece. How do we engage them to meet the needs that sometimes is above our capabilities? And so, that's some of the things we found out. So Darcy's been very instrumental in creating some of those relationships and doing that outreach and not thinking that she has to do it all herself. So, addictions and mental health go hand in hand, and we're seeing a big rise in the number of people who are having addictions issues. And so that's, her caseload has increased and for just one person. And so trying to look after her own mental health and, drawing on the team for sure.
Susan, I think Darcy has joined us and she may want to say a few words herself.
Thank you, everyone. Sorry about that. Wouldn't be, COVID times if we didn't have all of a sudden internet disconnect. So I apologize about that. Hi, everyone. So yes, I'm Darcy Reid. Thank you, Susan, Jeff, and anybody else that might have added to my part. I appreciate that. Again, team setting, right? That's a perfect example of how we work together. We all work very well together. So anyways, everyone, so I am of Mohawk and Irish settler ancestry. I grew up in Belleville, Ontario, but my family is from Tyendinaga as well. I am a registered social worker by trade. And again, most like other people in my team as well, I am new, a recent grad. I graduated in 2019 from Trent University with my Bachelor of Social Work. And prior to that, I had received my social service worker diploma at Loyalist College in Belleville. Same with Sarah, worked in this team, in this role for just over a year. I was actually one of the first hires for the IIPCT, and it's been quite amazing to see how it's gone from a, three-man show to having an entire team behind us and having a building. So that's been amazing. And as well, similar to what Kiowa had talked about, this role for me really represents so much more than a professional. This really represents my coming home. Susan had talked about, having that disconnect, living urban, growing up and having enfranchisement in my family, growing up without culture, without language. So this role is special to me. I've really learned how to connect with my culture, learning language, engaging in practices, and learning about my family lineage in the territory. So that's quite special to me as well. In terms of my services, I'll just add on to what everybody else had said. So you'll see the title there is Adult Mental Health Worker. So my role specifically is for people that are 18 years and older. And again, with the rest of our team, we support Indigenous individuals and or their families with that non-status blind, like Susan said. Overall, I would characterize my practice and my approach as strengths-based and client-centered approach in order to promote that collaborative working relationship with my clients and our other patients of the clinic as well. More specifically in terms of services, so I provide a psychosocial initial assessment on the individual, the community, and the social level as well, really to see the person in their environment and to see what their realities are on those three levels. Again, similar to what Sierra was saying, creating that plan of care based on goal setting is really what I like to stick to with my clients. And again, using that medicine wheel as a template to create goal setting, to look at the different areas and domains of the medicine wheel, to think about areas in our lives that we haven't necessarily had the time or the opportunity to focus on, right? Now we're seeing right now the importance of physical health, and we're also seeing the importance of mental health too, right? In terms of this COVID time. So anyways, I use that template to really have a conversation with my clients to talk about, okay, so these are the areas that you're looking for support for. How can we create goals to meet that need? As well, case management, counseling, education is another big one. Both ways, again, collaborative approach, me learning from the clients and the clients maybe learning new concepts or something like that from myself or from other team members. Resource and referral, that's a big one, both within our clinic or other MBQ programs, or externally as well. And virtual programming, of course, like we are doing tonight, with other programs in Mohawks of the Bay of Quinte as well, the Community Wellbeing Center. For example, the recent one that I did with Jamie Kring, our community development worker, was the holiday stress management workshop, and that was kind of fun. It was nice to kind of wrap up an interesting year, to put it, to say it nicely. So that is sort of what I do, the different elements of my work. And of course, I think it's most appropriate to say, I saw somebody comment, in the age that we're in right now, a lot of my work has been dealing with COVID-19 and how it has affected mental well-being, specifically in terms of anxiety, social isolation, grief and loss. That's been a major reoccurring theme, of course, for my work. And like what Kiowa said as well, it's been interesting to kind of set my career trajectory, in this time. And again, holistic practice is what I really try to embody, again, using that medicine wheel, doing referrals culturally as well. Also engaging in cultural practices, teachings, things like that myself. That's been a big one. And of course, another really important part of my role, similar to what Susan was saying, is networking with our catchment area, like all the agencies, services, programs within that, to really build those relationships, because the relationships are so important to build community. Yeah, so that's about me. Yeah.
Thanks, Darcy. One of the big things is about the support care coordination and cultural safety. And here I would just like to talk a little bit about how, a lot of people say, I've done the online course. And I think that's a great start. But really, cultural safety is about relationships, and it's about knowing your area. And so I think there's next steps to that, creating cultural safety. So doing the online, piques your interest, and you're not, to me, you can't tick the box that you have cultural competency training. It's about relationships, face-to-face relationships, and thus building trust. And it takes time to build trust. You need to remember that too. It just doesn't happen overnight. So I think, calling on the team to come and do some of that cultural competency training above and beyond the online course. And I know that's really being pushed, and that's fine. But like I said, to me, it's just a start. I think there's more that could be done. I'm not sure who on the team was going to, somebody's going to talk more about this, or we're just moving on.
Susan, I'm thinking we're getting on in time here, and I think either we can open this up for questions, or we can go on. We did prepare a brief case study as well. I'm not quite sure where we should go from here.
I could do a quick wrap that these are the programs and services we have right now. We were looking at, full-fledged clinic, OT, PT, the whole 9 yards. that we're not there yet, but we are looking at in the future, who knows how far into the future, hopefully not that far, that we are able to do that, to bring on extra services. Right now, there are services in the community who offer these, you know, as I have up here on our slide about specialty services, and that's about creating, again, those relationships and making sure we're referring people to places that are culturally safe for them. And as I think there was a question in there, or comment in the comment box about, are we looking for more people? Absolutely, we're always looking for people to be on our advisory. I believe there's one person right now from Kingston who sits on that. But, you know, send me an email or, you know, give me a shout, and absolutely we can look at bringing more people on. We just started with whoever we could think of, and more people are coming forward. So absolutely.